Hello everyone, my name is Jaspreet Chahal. I'm currently enrolled at BCIT for the Breastfeeding Experience course, and for the purpose of this particular assignment, I will be discussing blocked milk ducts in a mother with a tongue-tied infant. So let's begin. I will be using the Situated Clinical Decision-Making Framework as a guide throughout this presentation. As we all know, the decision-making framework is made up of 5 main components. These include knowledge, cues, judgment, decisions, and evaluation of outcomes. We'll begin with blocked milk ducts. A blocked milk duct is a duct that has either restricted flow or milk stasis, which results in a backup of milk in the breasts. If milk is made faster than it's removed, it gets forced out of the duct and into the tissue of the breast. This can often be confused with early stages of mastitis. Blocked ducts result in a localized area of the breast that has not been emptied and occurs when the baby does not drain the breast well enough when feeding or milk is not moved in between feeds. The most common causes of blocked ducts are infrequent or missed feedings and inadequate milk removal. Other causes include stress, fatigue, and local pressure on that area of the breast, which could be from restrictive clothing or a seatbelt, among others. Because of the discomfort associated with this, the mother's willingness to continue to breastfeed may be impacted due to the pain, tenderness, and irritability that accompanies a blocked duct. This overall impacts the mother-infant dyad relationship, as a mother may want time to herself, to rest if she's feeling unwell, and skin-to-skin contact may be lessened. Here are a couple of pictures illustrating normal ducts versus ducts that are blocked due to milk stasis. Note that the blocked ducts are dilated and filled with milk, which may present as lumps in the breast. Let's go over the other cues of a blocked duct. So signs and symptoms of blocked ducts include localized breast tenderness or pain, swelling in an affected area of the breast, reduced milk flow, an apparent lump on palpation, redness around the lump. It may be warm to touch, and often the woman presents with a low-grade temperature. Let's move on to tongue tie, which is also known as ankyloglossia. This is a congenital anomaly in the infant characterized by an abnormally short lingual frenulum, which may restrict tongue mobility. It is classified based on the degree of fusion between the tongue and the floor of the mouth, and for this reason, it may or may not interfere with successful breastfeeding. Here are a few images of what a tongue tie can look like. Note in the middle picture the positioning of the tongue when the infant is latched onto the breast. Due to the tongue's inability to move past the lower teeth, the latch may be compromised and ineffective. Let's explore this further. Signs and symptoms of tongue tie in the infant include difficulty lifting the tongue to the upper teeth or moving the tongue from side to side, trouble sticking out the tongue past the lower front teeth, a tongue that appears notched or heart-shaped when stuck out, difficulty with latch and breastfeeding, unable to maintain a seal around the breast, which may be evident as milk leaks out from the sides of the infant's mouth, inadequate weight gain for the baby's age, the infant may have reflux or be colic, gumming or chewing mother's nipples, baby may be gassy because of intake of air while breastfeeding, clicking noises while suckling, excessive drooling, and baby may even be choking on the milk or popping off the breast to gasp for air. Signs and symptoms of tongue tie that may be noted in the mother include cracked, blistered, and bleeding nipples, plugged ducts, discomfort while nursing, thrush, mastitis, and flat nipples post-feed, sleep deprivation because the baby is not able to nurse efficiently. The baby may compensate by nursing more often and longer, including at nighttime, and compromised milk supply. Ineffective emptying of the breasts results in low milk production. Remember, milk production is based on the principles of supply and demand. For a moment, let's direct our attention to the normal process of breastfeeding and what we should notice when an infant is feeding well at the breast. The milk sinuses are massaged by movements of the baby's tongue and by pressure from the lower alveolar ridge, causing the release of milk, which is ejected through the nipple. The tongue protruding over the gum ridge protects the nipple from being squashed painfully and even damaged by being caught repeatedly between the upper and lower gums. In a tongue-tied baby who is unable to bring his or her tongue forward past the gums, we may notice damaged or bleeding nipples. Peristaltic movement of the tongue rippling from the front of the tongue to the back, strokes the breast and draws out and maintains the flow of milk. These movements of the tongue also stimulate the nipple to elongate so that it is pointing down the baby's throat and directing milk towards the esophagus. Most babies can empty a breast in 10 to 15 minutes with efficient sucking. Next in the framework is judgment. So what could be happening in this particular scenario? In an infant with a tongue tie, the infant may struggle to establish an effective latch, which results in an inability to effectively suckle and move the milk as explained in the previous slide. This results in milk stasis, which ultimately causes blocked milk ducts. As nurses, it is our role to protect, promote, and support breastfeeding for all mothers. This can be done by assisting with repositioning the baby to establish an effective latch, encouraging the mother to feed for longer durations at each feed to ensure adequate milk removal, alternate between both breasts to ensure both are being emptied and milk stasis is not occurring, using hand expression after feeds or in between feeds if the infant is not feeding well enough. If the infant requires additional milk after feeds, supplement feeding with express breast milk. This can be done by feeding with a cup, spoon, or syringe. We must educate regarding the importance of moving milk and ensuring all areas of the breast are emptied. We may offer the mother either ibuprofen or Tylenol for the low-grade fever and pain that's associated with the damaged nipples. Moving forward, what can we recommend to mothers to prevent this from happening again? Most important is to keep the milk moving. Stress the importance of hand expression and massage. We may recommend breast pumps if the mother is not hand expressing adequately. Educate regarding hot showers and warm compresses to soften the breast, and discourage the mother from wearing tight or restrictive clothing. Remember, mothers want to ensure their babies are healthy and doing well. Poor weight gain or failure to thrive may prompt termination of breastfeeding and early weaning to the bottle. Considering the decisions made, the priorities I've chosen for a mother and infant in this situation are as follows. Number 1. Ensure that the infant is latching appropriately. We may need to consider a frenotomy depending on the degree of tongue tie. This is to be done by a physician or a midwife. The latch is vital to ensure the infant is moving milk efficiently. Consult a lactation consultant if one is available. If not, encourage and support the mother with different positions to enhance the latch. If additional support is required, we can also refer the dyad to a breastfeeding clinic. Number 2. Feed the infant and move the milk. It's important to remind the mother to keep feeding the infant, even though it may hurt. This will assist the mother to get better more quickly as the milk moves through the ducts and is emptied through the nipple. It's important to feed as often as possible and make sure there aren't long gaps between feeds. Also, we want to ensure that the infant is getting enough milk to meet nutritional requirements for his or her age. And number 3, encourage a positive mother-infant relationship. Both the infant and mother may be unhappy with one another at this time. It's important to encourage skin-to-skin contact as much as possible and try not to separate the dyad unless it is absolutely necessary. Finally, it's important to evaluate the care that was provided. In order to evaluate the effectiveness of the care, it is important to reassess the mother-infant dyad. A nurse can determine whether care was effective and if any further assistance is needed by assessing the following. How are the mother and infant doing with breastfeeding now? Is the infant latching appropriately at the breast? Has the mother been free of blocked milk ducts? Is she able to empty the breasts effectively if the infant is still not feeding well? What is the emotional state of the mother? Does she seem to be coping well with her infant? Does she have any other stressors or hiccups in the breastfeeding process? Does she have any family supports? Is there anyone else at this time that we could get involved and refer her to? All in all, the key points to remember are that tongue tie may or may not interfere with breastfeeding. However, if it is causing problems with the latch, we need to consider getting a physician or midwife involved to assess and determine whether a frenotomy will be helpful. We would need to educate the mother regarding the procedure and explain that it's non-invasive, virtually painless, and healing time is very quick for the infant. When it comes to the mother and blocked ducts, it is vital to explain to the mother how to avoid milk stasis and support the mother in hand expression techniques after and between feeds. Last, definitely not the least, stress the importance of the 3 E's of breastfeeding. Number 1 is breastfeeding early and often. Number 2 is breastfeeding effectively. So remember, this has everything to do with the latch and positioning of the infant. And number 3, exclusively breastfeeding. So that's it for me, folks. I hope that you enjoyed my presentation and were able to pull some information that may be helpful to you throughout this course. Thank you for watching.